So my TED Talk's going to be about schizophrenia and the stigma that America has put on schizophrenia and mental disorders in general. Considering 1 in 5 of Americans are diagnosed with some type of mental illness is interesting, and I think is more than likely more than 1 in 5. I just think less people are going and actually seeking professional help. But only 1% of America's population is suffering from schizophrenia, which is equivalent to about 3 million Americans. Whereas the U.S. population's 1 in 5 Americans are diagnosed with some sort of mental illness, and those are only the ones who are accounted for who go and seek professional help. So I chose schizophrenia for multiple reasons, but my fascination of schizophrenia started when I was really young. I had a great aunt who I found out was diagnosed with schizophrenia in her early 20s, I believe. She passed away when I was really little, but she was in her 30s, and it was due to organ failure. And ever since then, I've just been, very intrigued knowing that I had a family member with schizophrenia, and I've just always been interested in wanting to learn how their mind works and how they interpret things and how they react to people in their environment or to their environment in general. Another reason that I chose schizophrenia is because I recently gained a patient at a nursing home that I work at who has schizophrenia, and she's about mid-60s, early 70s maybe. I'm not sure of her background, and I'm not sure of when she was diagnosed, but it is fascinating, and I love observing her interact with people and the way she responds to her environment and the way she responds back to someone who speaks to her. And, she does, of course, have her moments where she's interacting with a hallucination or a delusion, and that's something that we can't hear, see, taste, touch like she can. So it is hard to talk to her, but at the same time it's very fascinating to see just how she interprets everything that's going on. So with that being said, let's get into the TED Talk. The overview of schizophrenia, it's defined as the inability to differentiate reality from non-realistic things. For the most part, it becomes present in late teen years or early 20s. In some cases, about 15% of cases, it's late onset, averaging from 40 to 60 years old, just depending on when the symptoms kick in. So schizophrenia is triggered, the symptoms are triggered by a stressful event in life. Whenever I was doing my research, I was looking at TED Talks, watching YouTube videos, and I saw that it was sort of predominant in college students or people around that age who, whenever they had their first symptom, it was after they moved away for college or, their first year of college. Something stressful like that can trigger the symptoms, and that's whenever the schizophrenia kicks in. So there are 2 types of symptoms, negative and positive. Positive being the abnormal behavior of an individual that's exaggerated, so like psychosis, which would be hallucinations or delusions. Negative, there's primary or secondary, and primary would be like the lack of apathy. They generally don't care about something that they used to love to do, like a baseball player doesn't even want to practice, doesn't care to look at baseball type of thing. Whereas you have your secondary negative symptom, which would be like social isolation, and that can be due to the simple fact that they're having dilemmas with their paranoid mindset. So along with negative and positive symptoms, there's also physical symptoms like catatonia. This is either motionless or restlessness, so excited catatonia or stupor catatonia. And it's not really as common as it was decades ago, just because we have a better system to diagnose schizophrenia way sooner than they had back then, because it's just such a rare syndrome. Given the difference in symptoms, we have 5 subtypes of schizophrenia. The first one being paranoid schizophrenia, which is mostly positive symptoms and is identified with individuals' irrational suspicions. This type can be treated with antipsychotics, and for the most part successful, but an antipsychotic is not universal, meaning it doesn't work on everybody. So there's always, it's either going to work or it's not, but does have high percentage of working. The next one is disorganized schizophrenia. This is disorganized symptoms, but in order to be put in this subtype of schizophrenia, you must show all symptoms within this category. So the next one would be catatonic schizophrenia, which, like I said previously, is not as common. It's actually very rare nowadays. But this is the decrease or increase in movement, and it can go to the extreme extent of resisting all mobility altogether. Undifferentiated schizophrenia is the fourth subtype. This is the category you're put in if you don't show a dominance of positive or negative symptoms. You may have all of the symptoms, both positive and negative, or a mixture of it. But if you don't have a dominant, this is the category you're put in, because at that point, you cannot be put in the subtype of the three previous ones we've reviewed. And then the last subtype is residual schizophrenia. This is the patient who experiences symptoms but at a minimum extent, but they definitely do have symptoms occurring, so they're put in this category just to keep them on the radar spectrum. Okay, with the knowledge of the 5 subtypes, we're going to move on to the diagnosis of schizophrenia. So there's no actual diagnosis to 100% detect schizophrenia. Of course, you can use urine tests that can showcase hallucinogenic drugs that can lead you to the diagnosis of schizophrenia. You can do lab tests, imaging. Imaging would maybe detect a tumor, and that can lead you to the explanation of your, hallucinations, delusions, psychosis symptoms, and the schizophrenic symptoms that you're having. That can lead you to the diagnosis. But there is, to this day, not a actual test that can confirm schizophrenia. So the way that psychologists diagnose schizophrenia is through the DSM, which is a series of questions that touch base with positive and negative symptoms, and that's how they get the subtypes and categorize the patients. Even after meeting protocol of the DSM spectrum of some subtype of schizophrenia, before they are diagnosed with schizophrenia, they must be diagnosed with schizophreniform for at least 6 months. 70% of the people diagnosed with schizophreniform are later diagnosed with schizophrenia. Researchers focus on neurotransmitters when looking for a diagnosis of schizophrenia. Antipsychotic drugs are distributed to patients to reduce their hallucinations and or delusions. And this medication forms blockages in D2 receptors, also known as dopamine receptors. But like I said previously, antipsychotic drugs are not universal, meaning the D2 receptors can be blocked and work on some patients who suffer from schizophrenia, but not all, meaning there's a gap between the D2 receptors and something that researchers have not yet. So along with neurotransmitters, genetics are also evident. Studies show if you have an identical twin, 100% DNA, there's a 50% chance that you'll develop and be diagnosed with schizophrenia if your twin is diagnosed and develops schizophrenia. For fraternal twins, the percentage drops down to 15%, given that they don't share 100% the same DNA in terms of one developing and being diagnosed with schizophrenia because of the other. So besides genetics and neurotransmitters, environment plays a role in linking a diagnosis to schizophrenia. The development of the fetus in particular, such as premature labor, the lack of oxygen while in the womb, and maternal infections that happens during pregnancy have been linked to schizophrenia. Diseases such as celiac disease, where the immune system attacks its own small intestine, has been linked to schizophrenia. And finally, the use of cannabis shows more predominance in diagnosis. So psychosis is the main element of schizophrenia, one of the most predominant symptoms that a person who has schizophrenia will showcase or reveal. Symptoms of psychosis: hallucinations, delusions, disorganized behavior and thinking, speech patterns, and agitation/aggression. There are different types of hallucinations, but the most prevalent in someone who suffers from schizophrenia would be auditory, which is the voices that they hear and that they cannot differentiate of reality and non-realistic voices. Disorganized behavior would be like abnormal behavior of someone who usually has it together, but if it cannot be directly observed, that's whenever the anticipated speech patterns are looked for. Speech patterns include anywhere from loss of thought, a word salad, no meaning, and no understanding of the sentences that they are saying, or even preservation, which is the sense of going from one topic to another and say they didn't answer this topic. Well, 5-10 minutes later, they're going to answer the topic whenever you're on a completely different subject. Okay, so now we're going to move on to managing schizophrenia. So antipsychotic drugs are used to regulate D2 receptors within the brain. There are two types of antipsychotics, first generation antipsychotics and the second generation, FGA and SGA. So the patient will go through a trial to determine which medication fits them best. And the difference in these, SGA is usually preferred because there are less side effects, but the FGA blocks D2 receptors more. So it's just whatever fits the body of the patient best and whichever one they're more comfortable with. Once the meds are figured out, management then depends on the stage of the patient, which would either be acute or the stable/maintenance stage. So the acute stage is for the patient who had their first episode of psychosis or those who relapse from the medication. And then once they're in the acute stage, that's whenever the antipsychotics come into play, where they get comfortable with SGA or FGA, and whenever they feel they're comfortable, that's whenever they can move to the stable/maintenance stage. At this point, the stable/maintenance stage, the goal is to minimize symptoms and progress life outside of having the disorder of schizophrenia. Therapy is encouraged to work on relationships, work atmosphere, environmental things, and therapy, they also try and influence the patient as much as possible to minimize the use of alcohol and drugs. So in terms of prognosis for schizophrenia, prognosis is worse generally for males or early onset patients and family history of schizophrenia. So relapse is common with antipsychotic drugs, especially for those who have schizophrenia. That percentage is about 20%. Now, if the patient were to refuse their antipsychotics, their percentage jumps to 75% of relapse, and the baseline where they had psychosis, symptoms, hallucination, delusions, irrational behaviors, etc., skyrockets, and it is way worse than refusal and noncompliance is crucial for a patient in medications and staying on the right track of their treatment. And it's not because they are harmful, it's because their hallucinations and or delusions, the voices they hear, etc., they cause them to believe that the medication is more harmful than helpful to them. So in conclusion, I hope I gave you all who viewed this a better insight on schizophrenia and the challenges of those who suffer from it, what they go through on a daily basis. I hope this video provided you with the knowledge you were looking for in terms of learning more about this mental illness, and my hope is that this false stigma be turned around for the sake of those who have not sought help yet in fear of being judged or being portrayed as something that they are not. Thank you for coming to my TED Talk.